Good afternoon. I want to start with an interesting statistic, and then I'll give you guys a quick introduction on who I am and who Vijay is, and we've got a little bit of a slide deck to walk you through. It's interesting stat here. Every 4 years, the frontline staff of a hospital system in the U.S. completely turns over. So this is the staff that's working on discharging all of the patients that flow through that hospital system. And think about that. Every 4 years, you're losing all of your tribal knowledge, all of that accumulated bits of insight that help you discharge really complex patients out of your hospital system. And so the little things like, oh, who's that DME company that will do charity work for us so that we can get this patient who doesn't have insurance discharged back home with the DME that they need? And oh, who is that long-term care, that nursing home that will take a look at these really behaviorally complex patients and it's got really good staffing that can take this patient who suffered a TBI and has got some really challenging behaviors, can't go back home with his family, but really needs nursing level care. What is that place? And if you think about that, every 4 years, all of that knowledge is leaving the organization. And so, what's the result? You've got your older adults who are dealing with complex medical issues flowing through the hospital system, staying in hospital beds far longer than they need. Their acute issues are dealt with. But because these little nuances, these little bits of insight aren't available to the team because the team's turned over, the patient sits. And this ends up manifesting in a lot of interesting ways. And some of those are outlined below there. The big things that we see, there's just throughput problems at hospitals where the emergency room ends up backed up and you've got lots of people who need acute beds, but no acute beds available. That's a problem. But from a patient level, you've got a patient who no longer needs acute care. So now they're sitting in this bed. So um, now they're coming up, their risk profile is increasing substantially around avoidable infections and wounds. And you've got decompensation issues to think about. And then there's just the overall patient experience. It's just miserable sitting in a hospital bed when you just want to be out of the hospital. So, yeah, as I mentioned, my name is Patrick Mish. I'm joined by my co-founder, Vijay Varma. We run a company called Silverstay, and our whole focus is around helping hospital systems really supercharge their discharge process. And we bring a lot of expertise, a really great network. And what we really want to get into today is really, really interesting workflow that's built on large language models that help solve for this problem of every 4 years losing all of your tribal knowledge. So with that, I'll turn it over to Vijay for a quick intro on his side. He's going to walk you through a demo to get us started.
Thank you, Patrick. Um, so really excited to be here, everyone. Um, a little bit of my sort of past, present, and future. So I was previously at Hopkins for probably around 12 to 15 years. I got my PhD there. Um, Patrick and I both in very different areas. Both have PhDs. Present, I'm the Chief Scientific Officer at Silverstay and co-founder with Patrick. And the future, our goal is to work to be a nationwide company that's managing 2 million discharges a year. And so Patrick and I both get super jazzed up and excited about discharge, right? Everything after a patient is clinically ready, a discharge order is put in, what happens next? Um, and the big issue that Patrick mentioned, as he laid it out here, is that particularly with complex cases, there's just a dearth of knowledge around how to manage these because of turnover in the hospital space. And so um, part of the solution that we've put together, and it starts with um, our AI navigator called Luma. Um, the goal of that navigator is to do two very specific things. Okay. First is provide social workers and case managers with a tool that aggregates over 10,000 complex cases and the internet. So all the internet resources. And you can take a newly minted social worker or case manager, and on day one, they're able to manage pretty complex cases. And so we'll talk about what's at stake and all of that. Patrick mentioned that a bit, but we'll get into that. But I wanted to dive in very quickly to a couple demos so you can see sort of where we are in our dev process. So in terms of just very quickly, in terms of like meeting hygiene and things like that, number one, huge thank you to Anne. Doing this stuff, we get to talk about tech and all that kind of stuff. Coordinating these things and getting them run smoothly is extraordinarily difficult. It's like herding cats. Anne has just been awesome throughout the process, and I really appreciate her coordinating this and helping us get this right and get in front of you. So thank you to Anne. Number two, just because there are a large number of participants, typically we really love in person and screams at us of enjoyment and anger around things that you like and don't like about our work, but a little harder on a virtual space. So what we're going to do is everyone is muted and the videos are off. However, we would like engagement. So use the question and answer box. Patrick is going to be looking at that. And any questions that come up, Patrick's going to interrupt me. We're going to address those questions. If those questions are going to be addressed later on, we may hold out on those. But certainly, we're really excited about engagement. So use that Q&A box, as frequently as you'd like, so that we can keep this engaging. All right. Okay. So case example. All right. You want to imagine yourself as a early social worker or case manager. Okay, there's a 66, and this is a true case in Baltimore City. A 63-year-old El Salvadoran patient is in Baltimore City who does not have insurance, not eligible for insurance, was extubated, however, can't swallow, needs tube feeds. Family is highly engaged, however, does not speak English and has very limited funds. The hospital care team has recommended skilled nursing. Rehab, however, this is not possible due to insurance constraints. Okay, this is a 20% issue, right? Edge case, 20% issue that drives 80% of a social worker or case manager's work on a given day, right? Simple question. What do I do with a patient like this? All right. So I want to talk about what, like sort of the gold standard that we measure on, right? Which is what actually happens. So we do know the outcome of this, and I want to go into that. But before I do that, let's run a couple of our models. I'll describe them briefly. Let me exit out. Let me copy this case. Okay, exact language. All right, we're going to run this in, with 3 different models, all of which have like interesting base model, lots of post-training work we've done on top of those, but I want to show you the results from all 3. So we're imagining ourselves as a social worker. We've just received this really complex case, and we're using Luma to solve that. Okay, we're going to start with GPT-4 plus Luma post-training. And I'm going to start, let these models work while I am talking. We're going to use Grok 3 again with post-training. We're going to use specifically the deep search capacity, deep search option here. That's going to take a while. So again, we want those to run. And then we're going to use Llama 3, or Maze, I think it's how it's pronounced. Open source model, again, with Luma post-training. And let's get those running. Okay. All right. We'll come back around to those. All right. So let's talk about what happened, right? Okay. This is a cool patient, right? Because it has many levels of sort of complexity to it. All right. We have a patient that is uninsurable. Okay. So all the post-discharge options that would typically be, he's very stable, right? So that would typically be used in this case. For example, a quick discharge on a skilled need He has a new tube, so a skilled need to skilled nursing would typically happen if you have Medicaid or Medicare. Okay, this patient does not have that. Um, Private pay funds are limited. So from the financial side, private pay funds are limited. So we don't have potential private pay options that would support a discharge from the hospital. Also, relatively clinically complicated, certainly not independent. All right. What's not indicated here is that he has, ADL needs across all his activities of daily living, needs at 24/7 supervision, etc. And so we have complications on the clinical side, right? So there's needs that need to be met 24 hours that require some level of training into providing those needs. We also have finances that are extremely constrained on the private pay as well as entitlement benefit side. Okay, so no private insurance, no Medicaid, and of course, no Medicare for this patient. Again, what do we do? Let's fast forward to the gold standard. What happened? Okay, and then let's go through all our models and see what Luma produced for us. Okay, what happened? This patient ended up staying in the hospital for 53 days. Okay, the first 3 weeks were spent essentially trying to understand, could the patient get emergency Medicaid? Was that an option? Is the patient waiver appropriate, which is something in Maryland that's available to patients? Would Is there such a thing as a charity bed in skilled nursing? And as you could imagine, when a social worker has 18 cases, of which 9 are discharged today, a case like this ends up sort of going on the bottom, and you end up not working on it frequently. Okay, we get through 3 weeks. Finally, leadership gets involved and says, "Why do I have a patient in here, that's been in here for 21 days? What has been done? Seems like nothing's been done. How long has the patient been medically stable and ready for discharge? Well, it's been, almost 2.5 weeks. What's going on?" Eventually, at day 53, the patient discharges. Okay, what happens is the family is brought in with an interpreter. Family is engaged, was brought in with an interpreter over a course of a series of a week plus. The family was trained on tube feeding. It was identified where tube feeding supplies and other DMEs could be provided via charity in Baltimore City. And finally, on day 53, the family came in. A wonderful family came in actually with a mattress in their car, in their station wagon. The patient was placed on it. They took the patient home, and the patient is doing really, really well at their home. Okay, so really solid outcome. However, it took 53 days. Okay. Um, Now, what is a better version of this, right? Can we do this kind of work in 7 days, in 3 to 5 days, with Luma assisting a passionate, however, early career social worker or case manager? Our hypothesis is yes, and we've been able to prove it out in a number of different hospital settings where we currently work. All right, let's go through each one by one, and let's see what Luma, based on different base models, same post-training in all three. Let's see what Luma tells us. Okay. All right. A lot of text here. So what I'm going to try to do is zoom in and highlight the big pieces. Okay, we got the right discharge recommendation, home with custodial care, supported by family as the primary disposition. Great. They let us know that while appropriate as a clinical setting, SNF is not financially feasible, and the engaged family can potentially support tube feeding care at home. And by the way, this is an interesting one. We didn't actually cheat on this. So we didn't pre-train on this case, which would have been, that's not fair. So this is actually one of the cases that this was not included in our post-training data set. Financial considerations, they fall into other, including charity/hospital contracts since they're uninsured. And again, discharge home with engaged family is appropriate. Charity funds to provide equipment. Okay, so now we have an idea, right? But what really is actionable? Okay, we got to get to action and what happens today. All right, timeline. Model thinks we can do it in 3 to 5 days. Objectives are arrange peg feeding education, coordinate home enteral supplies and DME delivery, determine if hospital charity funds can support initial home health or supply costs. And then it runs into the discharge barriers. Okay, now we're getting closer to what is actionable work, but we're not there yet, right? We need to know what can we do today? What can the social worker do today or case manager do today to meet that 3 to 5 day discharge goal? And so today's next steps, page the bedside nurse and dietitian to schedule peg feeding training with family using an interpreter. Number 2, refer to hospital charity program for coverage of 30 days of enteral formula, feeding pump, and supplies. Also ask the certificate of leadership if short-term home health can be included. What's really cool that I won't show here is there's also Baltimore-specific equipment vendors that the model can provide with Spanish-speaking home health providers. So the social worker knows exactly who to call and when to call, as in if it's within today's next steps. Okay, let's see what Grok 3's deep search lets us know. Again, it's still working, so why don't we let it go? It's been 7 minutes and 4 seconds. We're probably overpowering the we have an overpowered model for this, but the outcome is actually quite interesting. So we'll let that go. And then finally, the model Llama 3, where we control inputs and outputs. It's a little bit more modifiable or customizable, rather. We see that, let's see what it says. The most appropriate discharge appears to be a skilled nursing facility. However, it's not possible. The next best option would be home with home health services, to provide the required tube feeding and skilled nursing care. So we're getting there. We're getting to a pretty similar outcome with this this open model. Timeline, 3 to 5 days, very similar timeline. It indicates objectives, assess patient eligibility for Medicaid coverage. That is not a helpful next step because we know that that's not possible. So off a little bit with some of the objectives, suggesting that the base model is not quite as good, which we know, of course, that the Llama Meta's base model is not as good as either Grok or ChatGPT. And then finally, next steps. One of them is good. Reach out to charitable organizations like Catholic Charities, which is specific to Baltimore. And then it says something about if SNF placement is feasible. So we've gotten probably 40% of the way with this the open model, Llama 3, but not quite as good as ChatGPT. Let's see where Grok is right now. We're still working, so we can come back around to it in a second. All right. So pretty wild in my mind, right? So what have we put together here with Luma? Again, the accumulated knowledge of over 10,000 cases that we've worked over 8 years in collaboration with hospitals as part of post-training, and to give social workers in their hands a way to navigate some pretty complex cases.
So, Vijay, before you tangent off of this,
Yeah,
the two interesting questions from Adam Green relating to the data.
yeah,
One focused on how did you select, collect, and validate the initial training data? So this would be the 10,000 cases for your AI model,
yeah,
considering the diversity of cases in assisted living and care transitions.
yep. I love that. I love that question. Okay, so what is the post-training data set that we're really training these models on? So it starts with what our work with you can see this slide here, which helps here. Okay, so our work over the last 8 years, obviously the AI-powered workflow has been something that really over the last 2 years has taken a big role in what we do. But we have a Maryland-based team of licensed social workers and nurse case managers embedded in hospitals, a curated post-acute network with lots of ALFs, long-term care facilities, SNFs, LTACs, et cetera, with lots of data, right? So that's what has accumulated over 8 years. What we do is obsessively transcribe everything, of course, with the permission of who's speaking. So whenever we work on complex cases with the case manager, with the patient or family, we're always transcribing. We're using those transcriptions as a prompt response data set that we create. That's our post-training data set. Those data sets are explicitly are expert case managers interacting with all the individuals that are one interacts with when they're helping manage a complex discharge from the hospital to home, post-acute care, or wherever else. Okay, so the training data really, that's sort of the raw training data, that audio file. Okay, and then from that, we actually use another sort of processing LLM to generate the kind of prompt and response data that we're going to use for that we use for training. So that's what the Luma post training is. And we also use a combination of another LLM, right? We'll show you some of the architecture we have underneath this, another LLM, as well as highly trained complex case managers to essentially tag the data, to identify prompts and responses that may be inappropriate, to identify prompts and responses that don't get to the actual outcome, that need to be added to, subtracted from, etc. So we're really, we're tagging using a combination of an additional LLM plus a set of human complex case managers on our team. Hopefully that answers the question.
And I think it leads nicely into one of Adam's other questions is what measures do you take to ensure ongoing data quality,
Yeah.
address biases, maintain privacy, et cetera?
Yep.
Uh, and it sounds like the answer there that you laid out, Vijay, is really focused around the expert team that's
Yep.
reviewing the output
Yep.
and tagging the data as it's going in
Yeah.
for training.
Exactly. And what we'll get to in a few slides, what time is it? 12:20. This is 12:20. So I want to, I'm going to rush through some of the other slides because I really want to I want to have everyone have enough time for question and answer. That's stuff I love. And Patrick, Patrick and I both love that a lot. So, but we will get to a slide where we talk to some of the other questions that were brought up just then, or some points that were brought up just then, which includes um, um, I think it would relate to ethical consideration and transparency related to HIPAA compliance. We're going to get to all those. Some of those are on the architecture side. Some of those are on the sort of overall, like a broader structure or vision for the for Luma. So we'll hit both those things in a few slides.
You want me to hold off questions, Vijay? Is that what you're telling me until the end?
Uh, I'm more interested in what other people say than me. So Patrick, your call. If it's a great question or even if it's not a great question, I'm fine with anything.
Why don't you press
Um,
on for a little bit? There's questions building, and then we'll dive into them in a few
okay,
minutes.
awesome. Love it. All right, so we're about 22 minutes in. I want to my goal is to, at least by 40 minutes be done and have it be fully question and answer session. So I'm going to try to keep on to that. In the meanwhile, let's go back to Grok very quickly. Grok's still working. We'll get there. And I'll explain why actually deep search is interesting for us and use cases for that, whereas why other cases might not be use cases. It's pretty cool to see exactly what Grok is doing as well, but we'll get to that. Okay. All right, so why long hospital LOS matters. Patrick mentioned this, right? It's reduced throughput. Maryland has the longest ED wait times in the country, so it's a big deal what happens on the back end, the discharge side, right? If that is the bottleneck, right, you're going to start accumulating borders in your ED, and that only accelerates in October, right? October is when flu season begins, approximately when it starts getting colder, and that's when we really see the impact um, of of reduced throughput from patients that don't discharge as quickly as they should. Increased patient risks. Patrick discussed this. Big ones are obviously hospital-acquired infections. For something that we focus a lot on is older adult transitions, and so we see a lot of functional decline. For every day a patient, we're walking through the halls constantly of wings, mostly med-surg wings across the hospitals we work with. And it seems like every day a patient remains there beyond when they should. They're bed bound, right? And they're decompensating. And so there's a lot at risk, right, for when the LOS is delayed. And then of course, equally importantly, revenue loss due to unreimbursed days. Once a patient is medically stable for discharge and there are delays to that discharge, the hospital may not be reimbursed for those days. Okay, older adults, why, if for those that have spent time, many of you clinicians and healthcare providers know what hospitals look like, right? When you walk from bed to bed to bed, this won't be a surprise. So when you look at big drivers of hospitalization, that's our plot on the left. This is U.S. data from I think 2018. I don't believe it's changed significantly. You see that a significant percentage, those are the big red bars, um, um, are 65 plus. So 65 plus individuals really are driving a lot of the main sort of main disease instances that result in a hospitalization. It's not a US problem, it's a broader problem. So what you see on the right, zero is here, high age is over here. So this would be a right skewed plot. You see that, this isn't normally distributed. You have a fat distribution in terms of number of admissions in your older age groups, both in general hospitals and community hospitals. So again, nationwide and more broadly than that, worldwide issue around who is in hospitals and who are driving admissions. Okay, why controlling length of stay is a challenge? We saw a lot of these, we've mentioned a lot of these. The changing payer models is fascinating in Maryland, so I don't believe anyone's going to have state or federal insurance anymore. So their Medicare and Medicaid very soon is going to all be through MCOs, private companies. Medicare Advantage will be running every Medicare plan soon. We're seeing that trend, so that makes it challenging around managing payer models. The biggest thing is discharge planning is difficult. So next 3 slides will give you sort of a sense why. So when we talk about our edge cases, right, we're talking about those cases that soak up lots of time. These, while we did give an example of a unique patient that ended up going home, almost all these patients go to a post-acute facility. Home is just not an option. So there's a huge number of steps. This is meant to be a confusing slide to prove a point, right? There's a huge number of steps from the ED to discharge, ED on your left, discharge on your right, to get a patient discharged, okay? In every hospital, patients that have to go to SNF, it shouldn't be surprising, that's a skilled nursing facility or a post-acute facility, have significantly higher length of stay than patients going home or with home health, right? Shouldn't be a surprise. You can see through these steps from, the assessment needed within 24 hours, PT and OT needed within 48 hours in order to ensure that the auth is given for a patient to discharge within that specific time period. Sending referrals out to SNFs, getting an accepting SNF, getting family to agree on a SNF, et cetera, coordinating DME, coordinating transport. I mean, our social work and case management partners are just amazing in the level of complexity and what they manage, right? And this is one, right? This is one patient, let's say, that's going through this process. Multiply that by 15, 18, 25 for each social worker case manager, depending on their caseload. We know in Maryland that, there are staffing is not every hospital is staffed up. So what that means is more complex cases, more cases overall for each social worker case manager to discharge. So it is a problem that's only increasing in scope. So why is discharge planning difficult? For the similar reasons that, for the complicated nature of a transition to a post-acute facility that we described in the last slide. And also what we mentioned, and I'll worth saying again, 20%, 80%, right? So 20% of complex case patients take up 80% of social worker time. Okay, so a disproportionate impact on LOS. Social worker case manager turnover is high, like Patrick said. Within 4 years, you're turning over your entire social work case management team. Okay. Leadership, who, again, I've had incredible experiences with leadership across hospitals. There are often those 20, 25-year social workers, case managers, nurse case managers that move up to leadership positions that have seen just about everything, right? But that's not scalable, right? How do you scale that kind of advice across your entire team? It's almost impossible to do that if we're scaling through a person. And then knowledge of community resources, depending on the geography, is highly fractured at the hospital. Go to any hospital, ask any different social worker what is an appropriate, like Patrick mentioned, long-term care facility for a behaviorally challenging patient, which are the ones that might be more open to taking that. You'll get either, I'm not sure, different answers, or I need to check different, different sources. So it's not a sort of aggregated, centralized process generally across hospitals. This makes discharging planning difficult. And to draw it back just to like concrete examples, this example is why discharge planning for older adults in hospitals is extraordinarily difficult on our, on our collaborative partners in the hospital, our case manager, social worker partners. Okay, Miss Alvarez is a 69-year-old woman, poorly controlled diabetes, bilateral below the knee amputations, early stage cognitive decline. LOS right now is 14 days. She's medically stable, however, unhoused, no family support, requires a facility that accommodate both her physical and cognitive needs, and multiple SNFs have already denied admission. This is becoming not a edge case, right? This is becoming a case that used to be maybe, a handful a week. Now every single social worker in every single hospital we work with has a case like this or multiple cases like this. This is tough. This is a tough problem to solve. And that's what we're extraordinarily passionate on solving. And we've done some great work to get very close to solving that challenge. All right, so our solutions, we only have a few more slides, and then yeah, we're right on time. Awesome. Okay, so our solution that helps equip case managers that you saw an example of is Luma. Let's see what let's go back to Grok. Let's hope Grok has given us something. Yes, awesome. Okay. So what's really interesting about Grok, and Grok 4 just came out, is what Deep Search does a really good job of is like scouring the current internet, right? And so for us, when we have cases where we need a lot of we need to aggregate across potential community resources, identify the ones that are most appropriate within a specific geography. Deep search capabilities, not just with Grok, but deep search capabilities generally can do a better job of that than ones that don't necessarily utilize those. Also, um, uh, adding models together to create an output can also do that. So anyway, let's see what Grok has to say. Key points: they came up with home health, given the need for tube feeds. Exploring charity and community programs in Baltimore City, and it named two of them: in-home aid services and MedStar Health Home Care. Again, it does a good job of scouring local, very sort of niche questions, identifying potentially appropriate community resources. Financial considerations, obviously charity care or private pay. Financial steps and documentation, and then it mentions the barriers. This timeline suggests greater than 7 days. That's very likely more accurate than what Llama 3, or at least in terms of an estimated timeline, what Llama 3 or ChatGPT provided. Objectives to complete. It goes into a little bit more detail on submitting an application to in-home aid services, contact MedStar Home Health, engage Centro SOL for language support. Today's next steps. So for the social worker, what do I do today? Call Baltimore City Department of Social Services at this number to start the application to request a Spanish interpreter. Of course, that's if that's not available at the hospital. And then contact to determine whether charity care for home health services is required. Likely training for the family will occur on day 2 or day 3 once this is completed. And it provides some additional needs, notes, patient and family context that would be very helpful in terms of training for a novice social worker. And finally, like I mentioned, really good recommendations around local resources that might be able to provide charity resources for the case. Do they mention any repatriation? They do not, that I can see. But that's something, anyway, side note. Okay. All right. So what you just saw, 3 different base models on top of our, on top of our Luma post training, which was identical for all 3 models on purpose, to really see how these models differ. So what are our inputs? We can input multiple things: progress notes, family dynamics, payer types. Most importantly, what do social workers and case managers often need? What do I do, right? So that social worker question is often the input. Our LLMs that we use dynamically interpret and match and provide a next best action. Okay. There's model tuning that occurs. So this isn't just a wrapper around, some base model like ChatGPT. There's quite a bit of model tuning occurring, what we called before, Luma post training. And then ultimately, our goal is social worker has a clear plan that goes day by day, and then the patient can be discharged. All right. So big things um, that that we have incorporated into our models. Over 8 years of complex cases across Mish geography, proprietary health quality data on post-acute care facilities. So again, what is that long-term care facility that can accept behaviorally challenging patients? Let's make that information available to all social workers on the team. And then finally, geographic/hospital specific community resources. And our main goal, right, is very simple, right? What Luma is entirely focused on is what is the next step? How do I discharge this patient? Okay, very quickly on the Luma architecture, what's going underneath. This is just a Langflow visualization of what's going on. We won't go into the specific details, but the big things are we've partnered with Prediction Guard to ensure that what we're doing is HIPAA compliant. Our inputs are de-risked, so PII are removed. This is particularly important for closed models. Okay, human expert validated outputs, as I mentioned in response to the question. And we are integrating across EMR and referral software, right? So we're close to be able to go from a question about, for example, a long-term care patient that needs dialysis, where do I send this to? That can integrate EMR data specifically on that patient from Cerner and Epic and can access CarePort. So this is an AI agentic process, can access CarePort and set up that referral to those 3 identified facilities for the social worker case navigator to look at, okay, and press send. Okay, so we're taking a process that can take well over an hour, right? We're bringing that down to minutes when we integrate across all the tools the social worker uses, including the EMR and referral software. Okay, our impact, an example hospital, this impact was recorded between November and April, November 2024 to April 2025. We reduced 1.2 days overall LOS using Luma, 6 days LOS for complex patients. Luma operated across 150 complex patients, 900 avoidable days saved, and based on the hospital's calculation, 1.8 million in hospital savings over that period of time. And then finally, I'm going to leave this for the discussion if this comes up, but something that we think a lot about is how do you scale AI, particularly for older adults within the hospital space? What are the ethical, clinical, and operational implications? Things that really drive us are human-centered design. So our inputs that matter most is what does the social worker need? Our outputs that are really important to us is what is that plan that has been looked at um, or tagged by human experts, right? And we can argue how much that's needed with deep search capabilities with some of the new AI models. I think that's an interesting conversation. And then, of course, from our side, the importance of oversight, right? So one way to put it is gates, right? We can have these AI agents producing output, but ultimately, a social worker, case manager, we believe this through and through. A social worker and case manager bedside, there's absolutely nothing that replaces that. And so that individual knows the patient best, and that individual is the gate before anything gets pushed through what Luma produces. Okay. Contact information is here for myself and Patrick. We're right at, oh, cool. We're right at 12:39. That's perfect. So we have the next 41 minutes, 21 minutes, sorry, for questions. We're excited about implementing this continuing to implement this across hospitals. We're embedded in multiple hospitals across Maryland. We're excited to partner with anyone interested in this work. So of course, from the group, anyone interested in implementation research, AI, LLM, R&D, Patrick and I are super passionate about all those areas, always talking about it, always excited about it. So we'd love to chat. Contact information is right here in terms of our emails. I will stop my share and thank you.
So, Vijay, we've got a handful of really good and interesting questions here. Uh, one just a quick one to start. When you were running the model, running the patient through ChatGPT, which version of ChatGPT was that?
Or
4. Okay. Okay, this is an interesting one. So the
Or technically
family,
4O, but
Boro, yeah. The family caregiver ecosystem post-discharge are a key element of these complex patient discharges. So how are we factoring that in for these models and handling the families, their, understanding their capabilities, ability to handle the patient coming home,
yeah,
or being involved in care in one way or
yeah.
another?
I love that question, right? So tube feedings are a great example, right? There's, we think we can do it and there's actually doing it and what are the resources actually available. Our perspective is that, everything that you can do bedside with the patient and family to really understand what the capabilities are, it starts there. It does not start with the AI model, right? The AI model is as good as the inputs, right? So what we would, one thing that we emphasize, especially with our embedded staff in the hospital, is that very rarely is anything a yes or no question, right? Are you able to care for your father at home? It's not yes or no, right? It's let's talk through what that means, right? Let's talk through what the challenges might be, right? How do you do that in a non-pressure environment so we get to a really clear sense of is home an example for this case, which is a lot of labor to put on the informal caregivers or the family caregivers, is home actually a safe discharge option, right? The family is aligned on knowing that, right? Because they don't want to be able to, they almost always want what's best for their loved one. The hospital is very aligned on that, right? They don't want readmissions within 30 days. And so it starts with bedside conversations and that our staff go extraordinarily deep into understanding whether home really is a safe discharge and whether the family is able to manage this.
So it really gets at a division point between being able to have an AI agent supporting a social worker who maybe is new in trying to understand the steps, and then having someone who has some sophisticated communication skills to be able to go in and have that kind of conversation with the patient to understand what the capabilities of the family really look like. Is that a fair thing? Kind of a dividing
Absolutely.
point there.
Yeah, absolutely. An additional note to that is, Patrick and I would feel like one big metric for us, right, is can we get social workers and case managers? I think this is important across healthcare, back to bedside, right? Does this tool get social workers and case managers working on the most high value work, right? And that is a big measure for us, right? So does Luma ensure that social workers and case managers are doing what they went to school with for, what they're passionate about, and what they're best at, right? This is not an AI functionality being at bedside. That's a big measure of us for us.
So next question here from Kane, and I'm just kind of taking these in order that they came in. They're
Yep.
building in the queue, but we'll work our way through. How is the database maintained for completeness and current data on services? Online descriptions of services aren't usually specific enough for referral. In-person update from company is costly and not necessarily timely for database goals. Many states have aging and disability services databases with these difficulties. Great point.
Yeah, yeah, yeah. So databases for us come from three data sources, right? One is internet, right? Internet is good and evil, right? It has a lot of stuff, tough to determine what is actually up to date and actually would be helpful. The second is our own data that we've generated across, working on 8 years of complex cases. So um, we have a data set that aggregates daily around quality measures for skilled nursing facilities, long-term care facilities, assisted living facilities, what they're able to manage. And those are dynamic data sets. So when ownership changes or the delegating nurse changes or which can happen with post-acute care facilities, the data set, aggregates that information. And then the third is the hospital's resources, right? So every hospital often has a shared drive, right, that may or may not be used, but has resources in there. That's a little bit more static. So that's, more focused than internet, but the most static. And so internet is pre-training, right? So um, there's part of that. There's also just web search, right? So historical internet is pre-training. That provides probably the least community, benefit of community resources. Web search, depending on how the model uses that, can do a pretty good job, right? That's internet. And then our post-training two data sets we try to utilize, depending, hospitals, internal stuff, and then our proprietary data. That's how we ensure that the community resources offered are likely to be the ones where one phone call you get to the outcome.
So next question here. This is kind of interesting around long COVID. How are you following long COVID LOS? Those bedbound patients are particularly difficult to place. There was a recent example of a case that Cheryl notes here. This patient, I guess they were trying to push this patient to a state psych hospital, but there were no behavioral aspects.
Mhm.
Patient's 30 years old, but was basically comatose on feeding tubes. So not dissimilar from some of the more complex patients that we do see.
Yeah. Um, I would say that, you know, um, I'm going to answer this, sort of tangentially, but you know, I get to why we're actually not focused on, we're not clinically focused on things like long COVID. So when you look at sort of the grid of, the CIO at Stanford, this is his perspective, and I like it, right? When you look at a grid of, if you're going to implement AI, right, and you look at a grid of a sort of risk and complexity, right? Something that's high risk, high complexity, right? That includes making clinical decisions. That is something that you want to be the most careful about the use of AI, right? The most gates, right? But if you have high complexity and low risk, which we believe that case management and discharge planning falls more into that category, right? That if you look at that 2 by 2 table falls into that quadrant. It allows us to be like when we're focused less on clinical decision making, right? And more focused on discharge planning. It allows us to do more and support more with Luma, for example. So we actually, while we do collect data on, obviously we strip out PII, but we collect data on diagnoses and things like that. We're less focused on sort of how long COVID, for example, um, how that may be tracked over time post-discharge, right? We're actually intentionally staying away from clinical diagnoses or anything related to that. I'm not sure if that fully answers the question, but that's our, yeah, that's
Yeah, a patient that would be, whether it's long COVID or they've suffered a traumatic brain injury and are in a comatose state tube feeding. Uh, Similar types of solutions would be looked at from a discharge perspective. Is that kind of it?
exactly. Exactly, right. We rely on the providers to indicate what the clinical need is. That's an input, right? And so if that input is similar across long COVID or another, or for example, a TBI, depending on the symptoms, two very different things, but potentially some overlap in symptoms. Um, our process is, potentially similar.
All right, so moving down the list here. Adam had a follow-up question. Can you share what the cost was to acquire, prepare, annotate the training data for your AI model, and what major factors influenced these expenses?
Good question.
Don't know
Very
that
good
we
question.
have we have a cost number necessarily
Yeah.
associated with this, but what ends up happening is just by virtue of working cases, we collect the data and have a bit of a workflow and process to make sure the data is annotated, prepared properly, tagged, and going into the model. So it's a little bit hard to pin down. I suppose we could a cost number to that. Um, but I mean, that's one of the interesting things about deploying this technology now is in your current workflow, you can it's a bit of a leverage point to leverage your current workflow to help you train these models.
Yeah. Yeah. I mean, that's a great answer, right? So if you're doing the work of discharge, you're training our models, basically. Um, Now, because like large language models are developing so rapidly, we are, constantly doing product development on our side. So hard to measure exactly what, and I want to be always doing that, right? Because, large language models are changing uh, almost monthly, it feels. And so for us to say like, hey, we actually think a synthetic data set that Grok 4 creates might be better than, you know, or as good as actual complex cases. I mean, we couldn't have said that 6 months ago, right? But now we're going to be in the process of testing how good the synthetic model is, right? So can we generate 100,000 cases now using Grok 4? That's as good as 2 years of complex cases. I don't have an answer to that, but that, I mean, we're actively trying to answer those kind of cool questions.
A lot of questions to get through still, so we'll try to make these get these answered concisely with
Yes.
about 9 minutes left. Interesting question from Jose. Why not use a small language model instead of a large language model?
What is a small language model? I
Yeah,
don't
I
know.
don't know that I know enough about
Yeah,
that to help answer that
but I'm going to
question.
look that up.
Yeah, it'd be a good one to follow up with,
Yep.
and feel free, Jose, to follow up with us
Yes.
by email if you'd like. And there was a question about why Grok took so long to get to the answer.
I don't know. I've asked that, so I've tested this, right? I've, tested how long it takes for the same answer. And it's varied from like 2 minutes and 32 seconds to whatever this was, 7 minutes and something.
Yeah,
Um, I'm not sure. I mean, part of the black box of sort of neural networks and transformers are that
may
we don't
depend on
know
how much
exactly how it's
demand is
producing the output.
on
But
Grok servers as well right
yeah,
now.
it could be, yeah, exactly. Because I was worried, it was last night actually when I was looking at a bunch of stuff and likely there was less use.
Yeah.
Yeah.
Daniel has a question. Have you thought about testing your AI tool in a pragmatic, randomized control trial of usual care versus usual care plus your AI tool to assess the impact on patient outcomes and benefit to hospitals?
Yeah, great thought, right? Our driver, one of our big drivers are we getting the outcome that hospitals need, right? So are we reducing staff turnover? Are we reducing staff burnout? Are we able to reduce length of stay? For us, coming from the research side, when the randomized trial was seen as sort of the gold standard and also is the most expensive thing to do, right? It's been on the industry side, it's been kind of neat for me to be a lot more like translational focused without having to consider the randomized trial model. However, we do a lot of pre-post like testing, and we have a peer-reviewed publication in process that actually shows pre-post. It's not a randomized trial by any means, but it does show baseline and then change.
Jose actually has some feedback. He has some thoughts around small language models may be better than large language model. It'd be interesting to hear that.
So really quickly, look, a small language model is much better. Why? Because first, it's free. You don't have to pay for it. Second, it can be kept on a laptop. You don't have to use it in the cloud, so it ensures privacy. You have to think of a small language model as something that has 16 billion parameters. That's an overkill. You
Yep.
don't need a large language model that has a trillion parameters. You just don't need that. So most of the people who are using private data are learning that small language models is the way to go. There are thousands of them coming out in almost every industry. So please learn to use the small language models, save your money, and keep the privacy. You get better results because it's faster too.
Yep. I love, thank you for that comment, Jose. And the fact that it's important to be able to use this in sort of, you know, low sort of capacity environments, right? So being able to run it on a laptop is can be essential. So great point, Jose. Thank you for that.
All right, so 5 minutes remaining here. Let's go on to the next question. How do you incorporate comorbidity issues of older patients into model development? How personalized is your model?
Um, So the model is trained on lots of different older adult phenotypes that include, often that's from the H&P, so it includes a lot of different comorbidities. Um, the model is both highly specific and not specific, right? So the way it's not specific is that there are 13 places for someone to go post-discharge, right? That's not a lot, okay? So at the end of the day, we are trying to figure out how to get a patient into one of 13 places. And of those 13, there's three that like 90% of patients go. Skilled nursing facility, not including home, skilled nursing facility, long-term care, and acute rehab, right? So in some sense, it's actually not a complex, or there's no need for precision around that, right? But precision is absolutely needed because with edge cases like the ones we showed, one, those three don't work for that. But also the steps required and the barriers that come up for any given patient are very specific, right? So family says, yes, I can do this, and then they leave the face of the earth, and you have to make a decision on do you have to go guardianship, which is 4 months, or can you find a medical proxy, right? Unique. Okay, so the process is unique. The sort of output is not, right? It's extremely not unique. Yeah. And so
Great.
yes, the models do incorporate, because we have like thousands of post-training data points on prompt and barriers and solutions, prompts and responses. We have a lot of data that's extremely nuanced around cases that helps train a specific model.
So we still have about a half a dozen or so, maybe a little less than that questions, but I'm going to try to pull one out that I think is kind of interesting here to talk through. And the other questions, we'd be more than happy to follow up with the team via email. Feel free to reach out to us and we can have a conversation. So this question is the beauty and talent of the social workers mentioned, parenthetically, who often staff the hospital care manager role, is that they are storytellers, qualitative narratives, and listen to the patients and families, caregivers' stories and pain points. How are you finding their adoption of concepts of quantitative info and data?
Um, to me, it feels like the same as any. I don't see it as different from many other groups, right? You have early adopters, you have individuals that, like, the three sort of categories that I've seen, like early adopters, which is, normal individuals. They often use ChatGPT or some large language model in their day-to-day private life. You have individuals that are driven entirely by outcomes. Hey, I'll use your tool, but I'm not going to use it if it doesn't actually get me the outcome I need. So if it's helping, they're going to use it. And then the third ones are individuals that, are fairly stuck in their ways and slightly more challenging to use some of the additional tools. But we get there, right? Because ultimately, what you said in terms of narrators, the other piece is that these are individuals we work with that are highly, highly passionate and dedicated to their patients. So they are willing all across the board, willing to use tools if it's going to impact patient care.
And we're right about at time. So, and those questions that go unanswered, you are more than welcome. We would love to answer them for you. More than welcome to reach out to either Vijay or I. And I think Vijay just dropped the email addresses in the chat, right? Did I see that? So very easy, Patrick at silverstate.com or Vijay at silverstate.com. We appreciate your time today. This is really fun on our side to be able to share some interesting evolution in the discharge space that's affecting patient care in a big way. And appreciate the opportunity to take some of your questions and learn from you all.
Thank you both for joining us today.
Thank you, Anne. Thanks, everyone.
Bye.